So good morning, everyone. Welcome to this meeting, the Sacramento County Health Authority Commission, a special meeting. My name is Eddie Kirby. I'm the vice chair of the commission, but today our chair, Chet, can't be here. And so I'm going to convene this meeting with you all, and very excited to have a very great, important agenda here today to talk about the RFP, the Medi-Cal Managed Care RFP, and so we're fortunate to have Transform Health here, who's going to give us a great presentation. So I want to call the meeting to order now. There's not really any business this meeting, so it's more of a presentation, but pass it over to our wonderful staff, Janine, who'll do a quick little review, and then we'll move into the agenda.
Thanks, Eddie. I'm going to pull up the agenda on my screen. So as Eddie mentioned, we will be hearing from Lisa Chansawin and Don Hawkins Johnson from Transform Health, who will be presenting on the Department of Healthcare Services draft Medi-Cal Managed Care Plan request for proposal. And I wanted to share a review of the commission's timeline for feedback on the RFP. And I know that Lisa's team will cover this, but just to put it front and center for everyone's mind. So today is the in-depth overview of the RFP contents. There was a high-level overview that was presented at the meeting earlier this week. And then the Consumer Protection Committee and the Quality Improvement Quality Assurance Committee will also be discussing any comments or questions that they may like to recommend to the full commission, and that will be at their upcoming meeting next Thursday, the 24th. And then the full commission has a special meeting next Tuesday, the 29th, from 3 to 5 p.m. And it is at that meeting that the final comments and questions will be reviewed and approved for submission to the state by the July 1 deadline. Are there any questions at this point about that? Okay, seeing none, then I will pass it off to the Transform Health team for the presentation. Lisa and Dawn.
Great, thank you, everybody. Can you see my screen? Awesome, great.
Yes.
Hello, everybody. Good morning. It's great to be here with you today. We're going to do a deep dive into the Medi-Cal procurement package today. And just to run through our agenda really quickly, we're going to go over the goals and purpose as defined by the state for this procurement. We'll also walk everybody through all the different components in the RFP package. Please keep in mind, not all the sections have been fully developed yet. And so as part of our conversation, we're going to identify what components have sections that are developed and what that content looks like. We'll also clearly identify the areas where content is still under development and flag those for you. We'll be reviewing what is available in detail, as well as the proposed managed care contract changes. There's 3 managed care contracts, 2 of which are not available yet. The contract that is available is the standard federal contract, and so with some targeted changes that have been identified by the state. So we'll go through that. We'll also walk everybody through the available information on the evaluation and scoring process. There's still some changes happening. And then we'll go through the comment process and timeline, as well as provide some additional resources at the end. So if there are no questions, I'll go ahead and let's dive in. So the goal for us today is to walk the commission through the MCP procurement package in preparation for your upcoming meeting on June 29th and to support commissioners developing questions and comments. And so today our objectives are to review the procurement package in totality. And our goals are that commissions and stakeholders really understand and are prepared to comment on the DHCS objectives and goals, the timeline, the process, and major sections that are available and complete for comment. We also one of our other objectives is that the commissioners and stakeholders also understand which sections are still under development. And this deck has been developed as a reference deck. And so throughout, you'll see that we have identified page numbers. Those page numbers correspond and reference back to where you can find that item in the RFP main document. And so our goal is to provide the actual content where it is available, so you don't have to flip back and forth. But if you do want additional information, you can go back and read that content within the RFP itself. Great, so let's dive in. So here are the purposes and goals for DHCS for this procurement. The mission and vision statement presented here is the state's mission and vision for Medi-Cal writ large. And it ties back to the state's procurement objective, which is to be able to procure commercial plans to provide high quality, accessible, and cost-effective healthcare through established networks of organized systems of care, organized delivery systems, which emphasize primary and preventative care. And so these are important goals to keep in mind. This is also an area where the commission could weigh in if you feel that there can be additional refinement on the procurement objectives. And these objectives, more specifically, are tied to 14 broad goals. And so these goals, DHCS is really looking for managed care plans to demonstrate their ability to deliver on 14 goals, and they are quality. The state seeking plans to meet or exceed minimum performance levels for quality on the measures included in the managed care accountability set. The state is also seeking plans that can demonstrate ability to have access to care, ensure comprehensive networks that provide all members timely access to appropriate, culturally competent, and high quality care within time and distance standards. And those time and distance standards are timely access standards that are set by the state and state rules even beyond, for all plans, beyond just Medi-Cal managed care plans. In addition to that, the state seeking plans that can provide a continuum of care and manage members over time through a comprehensive array of person-centered health and social services, spanning all levels of intensity of care from birth to end of life. So that's what the state means by continuum of care. They also want plans that can provide children's services, specifically preventative and early intervention services, maternal services, and those that support social, emotional development and adverse childhood experiences. So really tackling ACEs and getting into the work around trauma-informed care. State is also looking for the plans to be able to provide behavioral health services, expand access to evidence-based behavioral health services focused on earlier identification and engagement in treatment for children, youth, and adults. In addition to that, they seek plans that can coordinate and integrate care. And what the state means by that is to provide coordinated, integrated care for all members, particularly vulnerable populations with complex healthcare needs. This will include the strategies articulated in CalAIM, as well as coordination with entities providing carved out benefits and services and other state and federal requirements. As part of CalAIM, the state's going to be making changes. Some of you may have already heard of some of those changes, like we're carving out prescription drug benefits, carving in transplants, to give you a few examples. State also seeks plans that can reduce health disparities, and by that they mean identifying health disparities and inequities in access, utilization, and outcomes among racial, ethnic, language, and lesbian, gay, bisexual, and transgender, and questioning LGBTQ groups and have focused efforts to improve health outcomes within the groups and communities most impacted by health disparities and inequities. Reason 8, increased oversight of delegated entities. State is seeking plans that can provide increased oversight of all delegated entities to ensure members are receiving quality care and services in accordance with the MCP's contractual obligations with the state. Sometimes in California, we have health plans that delegate to and subcap to other plans or other medical groups in shared risk arrangements, and that's what the state is referring to there. Local presence and engagement. I think this is an important one. State is seeking plans that establish and expand a stable local presence and collaborate and engage with local community partners and resources to ensure community needs are met. And then states also looking for plans to have emergency preparedness and ensuring essential services, ensuring continuity of its business operations, delivery of essential care and services to members, and to mitigate any potential harm caused by an emergency, such as a natural or man-made hazard or disaster or health crisis. You know, we're coming out of COVID slowly. You know, that is an example of what the state means by emergency preparedness, especially during times of health crisis. State is also, and this is an important one, looking for plans that address the social determinants of health. What they mean by that is they're seeking plans to meet the health needs of a member through methods designed to understand the overall circumstances of members, including capturing SDOH through coding and articulating a care coordination strategy that is inclusive of social determinants of health. CalAIM, state is looking for partners and is looking for plans to implement and support CalAIM. CalAIM is a multi-year initiative by DHCS to improve the quality of life and health outcomes of our population by implementing broad delivery system program and payment reform across the Medi-Cal program. So once implemented, the initiative will result in better quality of life for Medi-Cal members, as well as long-term cost savings avoidance. Next item, value-based purchasing. State is seeking plans that can implement financial arrangements with healthcare providers that link payment to value in the form of higher quality care, better healthcare outcomes, and lower cost of care. Such arrangements include, but are not limited to, incentive payment arrangements that reward providers for high or improved performance on selected measures or benchmarks. So really trying to get to the value equation, moving beyond just cost and quality. And finally, administrative efficiency. The state is looking for plans that can help reduce administrative waste and enhance efficiency across the program. So those are the 14 specific goals that the state is looking for plans to meet as part of this procurement. One thing to keep in mind, you know, as you think through these goals is how well do these goals line up with the commission's goals? Is there full alignment, or is there something missing here? Note that there's nothing on cost. In California, Medi-Cal plans do not compete on price or on cost because the state sets the rate for the plans. If there are no questions, we'll move into what the RFP package entails. So the state is providing a draft RFP through a public comment process. All stakeholders across the state are welcome to respond and weigh in during this process. And what DHCS is going to do is use these comments to develop the final RFP. There's 4 main components within the RFP. There's a cover letter. It provides information and instructions to interested parties to, you know, to the plans. There's also a draft RFP main document. This will be your main reference document, and the page numbers throughout this presentation deck tie back to this document. And this document provides information regarding the RFP process and instructions on how to develop the proposal, as well as the sections that have been developed. We've pulled that language out for you today, and we'll be going through that in a little bit. The state also includes RFP attachments. These are described in the RFP main, and we'll walk through those as well as a sample MCP contract. The contract is supposed to include sample, and it does include currently sample scope of work, terms, conditions for contracting as a result of this process, but significant components are still under development, and so we'll walk through those today as well.
Just for clarity's sake, I think it's important. Good afternoon or morning, everyone. My name is Dawn Johnson. I'm a senior advisor with Transform Health. I think it's important to know that in this comment period, not only are commissions weighing in, but the healthcare ecosystem is also weighing in. So the hospitals are looking at this, potential partners to the health plans are looking at this, stakeholders will be, other stakeholders will be, and the health plans as well, because they want to make sure it's positioned for their success. So they're going to be looking at the requirements and weighing in as well. So the state will get a diverse set of comments from a number of stakeholders, each representing their goals and objectives for this and what they'd like to see from the managed care plans. So I just wanted to make sure that everyone's aware of all the different viewpoints that the state will be mindful of in this process.
Thank you, Dawn. You're absolutely right. And just as a different visual for those who are visually minded instead of text, you know, this is another visual representation of what's in the RFP package. Many things are still under development. So for example, some of the attachments, some of the appendices to the operational readiness contract and the secondary height contract, those are still under development. And so those components aren't available for us to review. But there is no reason why, you know, if there are certain things that the commission would like to see in those items, you know, you could weigh in with the state and say it would be really great for the contract to include X, Y, Z. So there are different ways, and the stakeholders are welcome to comment on any aspect of the RFP package. All right, so a few other things. You know, a number of counties have submitted for county plan model changes. Sacramento is one of them. As a GMC county, there is a bill going through the legislature, which many of you are very familiar with. And one of the most recent things that DHCS has shared with everybody is, you know, the county plan model changes, there are deadlines and timing related to the MCP procurement. And so we'll review those when we review the timeline later, so that you can see how those two processes intersect. We'll also be, the other thing we wanted to flag for everybody is the state has made clear that for GMC counties, like in Sacramento, they are not going to award no more than 2 managed care contracts. And these contract terms will be for 5 years. Other things to note, there are 12 pass-fail minimum qualifications that all MCP plans will have to meet. And so these things are, many of these are items that include relevant work experience. There's like a minimum 5-year experience that's required. You know, all of these plans have to have NCQA accreditation or tell the state what is their plan to remedy and achieve that NCQA accreditation. They have to be Knox-Keene licensed in California. which means they have to be licensed and registered with the State Department of Managed Care. So these are minimum qualifications that all plans have to meet to even qualify to be a Medi-Cal managed care plan. And of course, many plans are going to be seeking county letters of support. It's not a requirement, but if the plan submits it with their proposal, then it will be considered as part of DHCS's evaluation. And the state is still developing the narrative proposal requirements and the evaluation and scoring requirements. You'll see that as we review those sections later on.
Lisa, just to chime in, sorry, if you could go back one more slide, just to clarify, SAC is not changing its model. It's still GMC.
Yes, Sacramento is still GMC, but this wanted to flag for everybody that the state's not going to award more than 2 contracts under the GMC model anymore.
And Lisa, can I, I mean, we can actually, this commission could choose to comment on that, for example, if we wanted to, right? If we feel like 2 is too restrictive, you know, do you have any insights on, because right now we have 5 plans in Sacramento, the other GMC county has, I think, 6 or 7 plans down in San Diego. Do you have any, you know, any insight on why the restriction to 2 and whether or not that's, you know, a positive thing for, you know, for delivering healthcare in the future? Do you know the reasoning behind DHCS making that change, what they're saying, why?
Sure. Some of the reasons that we've heard is for administrative simplification in terms of managing the Medi-Cal program, you know, for consistency, and also to ensure that, you know, for providers, you know, plans can operate slightly differently within a same geographic area. And so just to minimize the range of variation in terms of implementation for providers, that was another reason given by the state. You know, the state is looking at sort of how to transform Medi-Cal overall and become more efficient too. And so we've seen other states do this where they try, and if you think about it, you know, with the states also sort of outside of this body of work is having conversations about moving to setting rates not only on a county level, but on a regional level. And so as they contemplate regional rate setting, having fewer plans and aligning that also reduces the state staff workload.
Thank you, Lisa.
No problem.
I think one other thing to note just on that, Lisa, is with the potential loss of several plans because of what's going on with ECM and ILOS or CalAIM, all of the plans right now are working on that effort. And so as Lisa mentioned earlier, there may be some delegation of responsibilities to other plans. So you may see teaming that you wouldn't normally see in other markets of plans working together. So I think just understanding from the commission's perspective how that might look when the state contracts with an organization that, you know, delegates responsibility, which means I, Dawn, am delegating all the responsibility for managing my population to Lisa, and Lisa is responsible now for managing those populations. So it adds a level of complexity and management, although there's administrative simplification with, you know, who's ultimately responsible. When it comes to, you know, segments of how the plan operates, they could have 5, 6, 10 different organizations responsible for different aspects of care for the population. So I think although it may be simpler, it may be more complicated at the same time.
That's a really
Thanks,
excellent point, Don. You know, and this is exactly the case, to give you guys an example, in LA County. LA County is a 2-plan county with HealthNet as the commercial plan and LA Care as the public option. but we know that there's been delegation under both plans to other health plans as well as medical groups because of capacity issues and the need to ramp up. And so, you know, your point, Dawn, about who is this actually, where's the point of administrative simplification? You know, by minimizing and managing 2 plan contracts versus 5 plan contracts, that simplifies things at the state level. But if there is delegation, that adds complexity at the local level. That's a great point. Okay. So moving along, these next 2 slides I think are going to be really important, particularly as reference slides. So these are the sections with content available for review. The proposal cover page, and it's on page 37 of the RFP main document, is associated with attachment 1. The plan model county proposal selection form is as referenced on page 37, but that attachment B is parts of it is still under development. The proposal transmittal letter is actually available, so we'll be reviewing that section today. There's also a table of content that's required, which is a standard table of content tying back, so that's more instructions to plans. Executive summary, there's requirements there, and the proposing firm capability statement. Those 2 sections are probably, and the proposal transmittal letters are the most fleshed out currently. And so there's going to be materials that we'll walk the commission through today, where that would be a good area for reviewing that language and weighing in on. The narrative proposal requirements are still under development, as well as some of the attachments. So we wanted to flag for everybody what content was available for your review right now. This is your reference for that, but the stars indicate where content is only partially developed, and those additional requirements will be made available in the final RFP. Separate from that, there are quite a few sections still under development, in particular around the narrative proposal requirements. The proposal requires documentation demonstrating the understanding, agreement, and compliance with the Medi-Cal Managed Care Program requirements as stipulated in the sample primary and secondary contracts and other program material. All 21 sections that are in the NPR are currently under development and will be available in the final RFP release. And those sections are listed below. They are organization and administration of the plan. How will the plan go about organizing and running itself? There's a requirement to provide financial information and program integrity information. How will the plans manage program integrity? There's a section around management information systems, the quality improvement system. How are the plans approaching utilization management? Information required about the network provider agreements and subcontractor agreements. The provider's relationships, and so provider relations and how they will be handled. And what are the provider compensation arrangements? How will the plans go about marketing? Enrollment and disenrollments, how will those be managed and handled? Population health management and coordination of care. What is the plan's approach to managing populations and coordinating care? Just as important, member grievances and appeal systems. What does that look like when members have challenges? And broadly, how is the plan approaching, what is their approach to member services? What does their network look like and access to care, their full scope of services? There's going to be a section on community-based adult services, better known as CBAS, for all of you working in the long-term care space. they also wanted to pull out and call out how the plan would address mental health and substance use disorder benefits. The state also wants to know about MOUs and agreements with third-party entities. Also, what is the plan's approach to emergency preparedness and response? As we mentioned earlier, wildfires, pandemics, things like that do happen. And then finally, if there are county-specific requirements, those will be captured in that last section. So none of these 21 sections have anything available for review currently. They all have been indicated as currently under development and won't be available until the final RFP release. However, for the commission, it doesn't mean that you can't weigh in on these areas. You can ask questions, you can ask the state to include certain things in each of these sections. So for example, if there are challenges around the member grievance and appeals section that you want to highlight or that you want the state to have a special consideration and take into account as they develop these sections, this is an opportunity for the commission to weigh in. I'm going to pause there in case there are questions.
I'll say that this is the meat of the proposal. This is where everything is detailed out. This is where you learn who's going to be responsible for what. This is where you learn how often things will happen, how often assessments and reassessments will happen. This is where you learn about access and the availability of providers and where the network will be and what kind of network it is. So I think this is the section, although it is still under development, where you might just want to put a comment in each place to make sure that the things that are important to the commission are represented there. Even if you don't know if it's already in the works or you feel like it was part of the last contract, or if you know that there were things that were part of the last managed care contract that you don't want to see again, or that you had problems with or concerns about, please put it in that section, just so that they're aware of the issue. I think it's really important. It's unfortunate that everything is under development. That is really key to how these programs will run, but I think this is an opportunity to really identify, I would like to make sure that utilization management includes X. I would like to make sure that the provider agreements include community-based organizations, so those are the things that you can put into those sections, especially knowing that CalAIM is going to be folded in to their scope.
Great, thank you, Dawn. So in this next section, we're going to do a deep dive into the RFP sections that actually have content ready for review. So the first section is the proposal transmittal letter. The letter has to include 7 elements, and these are covered over the next 2 slides. The first of which is the letter has to identify all materials and enclosures being submitted as part of this RFP response. 2 is the name, title, contact information for a liaison so that DHCS has a main contact. The third item is a statement indicating the legal form of the proposal. So what are they? A partnership, an LLC? Are they a nonprofit? That statement has to be clearly included and clearly articulated. And they also have to include a statement about how the proposer meets the prior experience and demonstrates ability and has the demonstrated ability requirements identified in the RFP main, the qualification requirements and the experience requirements. So these are the 12 minimum qualifications. It has to do with, like, do you have experience running a public program? You have to have at least 5 years experience, as I mentioned before. you also have to have Mcp licensure. You have to like agree to all the state's contracting rules. So, you know, the state wants the proposer, the plan, to articulate clearly how it meets all of these requirements. The state is also asking for a statement indicating that the proposer has no affiliates, or if they do have affiliates, providing the information of who those affiliates are, and identify all persons and concerns who can exercise control or ownership over that proposer. So sometimes, you know, there can be plans that are owned by a parent company, and so the state would like to know who has the ability to make fiscal and controlling decisions for that plan. They also want a statement that the proposal is complete and a statement acknowledging that all costs associated with the development and submission of the proposal is entirely the responsibility of the plan, and they will not incur any state costs. This, you know, fairly straightforward for a transmittal letter, but this is also an opportunity to weigh in if you want the plan to also articulate, you know, anything else. Dawn, is there anything like that?
Yeah, I think it's also important to remember that this is a full and open competition. So there's nothing barring a plan that is operating in some other part of the country, I believe, to submit for this procurement. So you could get a plan that's not currently one of your 5, also put in a bid for this work. So it could be a fully unknown plan to Sacramento County. So please think about it. And with that respect, like, it's not just known entities. So what else would you want to know from an unknown entity that would be coming into your county?
Thanks. So the next section is the executive summary section, and this section is fairly straightforward. What the state's looking for is for the plan to articulate in their own words that they understand DHCS's needs and the importance of the Medi-Cal Managed Care Program and CalAIM, the tangible results that they're expected to achieve. The state's looking for the plans to provide a sincere written commitment to perform the scope of work in an efficient and timely way, and articulate how this project will be effectively integrated into the proposing firm's current obligation and existing workload. So especially when, you know, in light of Dawn's comment about, you know, you could have completely new plans, you know, make a bid in Sacramento County, you know, the state's going to want to know, you have an existing workload. How will you take, you know, and launch in a new area? How will you make sure that you meet the needs of this new area that you're taking on for Medi-Cal Managed Care? And finally, the state wants to know why the proposing firm should be chosen to undertake this work at this time. These are the 5 areas that the state has identified as required in the executive summary section. But they also note that additional requirements are currently under development and will be available in the final RFP. And this is, again, yet another area where the commission could also weigh in if there are, you know, if you agree with these 5 questions, or if, you know, there are some additional areas of information that you would like the state to seek.
Typically in this section, you'll see a re-articulation of the goals. So they will add, you know, a little bit of meat to the bones of the goals and the objectives of the procurement in this section. I think when you want to consider what do you want for your county, you know, how are you going to meet the needs of the actual individuals that you're serving? You know, so I think there might be a way to draw it down even further because those goals are rather lofty and big bucket items. So think about, you know, what else do you want to know besides a rearticulation of the goals that are in the proposal.
Excellent points, Don. So this next section, the proposing firm's capability section, is the big kahuna. This is the section that has the most content developed currently, and it's going to span the next 5 slides. And up on the top, you'll see the page numbers that this section corresponds to in the RFP main as well. And so there are a number of questions in this section. We'll go through them each. And then we can take questions at the end after we go through all 5 slides, unless there's something pertinent to a specific question on that slide. So, you know, so the state in terms of this section is looking for the plans to include a brief history of their firm. So when are they established? You know, any changes in their business history. So or organizational structure. So things like, you know, we were bought by this firm on X date or merged with this organization on that date. We changed our organizational structure from LLC to nonprofit or, you know, S Corp or whatever it is. Those are the type of things that the state is looking for in this section. They're also looking for a description of the proposing firm's goals that are relevant or closely related to the Medi-Cal Managed Care Program or that complements the Medi-Cal Managed Care Program. They're also seeking the plans to describe other existing and projected Medicaid and or Medicare contracts, projects, or obligations that they have and the resources required to fulfill each. They've asked the plans in this section to describe any foreseeable conflicts between the existing or projected obligations and in this proposal in respect to their business resources, their personnel, processing time, and financial resources. This is really about getting to, does the plan, you know, have the existing resources to meet the needs that they're trying to, you know, in the areas that they're seeking to serve and secure Medi-Cal managed care contracts. The third question has quite a few subsections. And so we're gonna go through the main question and each of the sub-questions. So the main question, question 3, is asking the plans to describe prior or current experience that qualifies them to undertake this contract. So this is where the plans can share, you know, their relevant experience, why choose them, and this experience requirement must be met by the prime contractor and not through any experience provided by subcontractors. So as Don mentioned earlier, sometimes plans subcap to other plans. While the state wants to see that the experience requirement is met by the plan that is applying and is the lead entity and not filled by having additional subcontractors underneath them. They have to demonstrate having sufficient experience, current investment, understanding, and success that meets all of the goals identified in the RFP main. So these requirements are, they have to have previous experience in administration and operating a comprehensive healthcare program for Medicare, Medicaid, or another health insurer or paying organization. So for example, an example of that would be like, separate from, and they would like to see in this section, the plans include the contract duration, what the scope of services provided, the healthcare delivery system models used, how many members were served in the geographic areas of their previous experience. And then under 3B, they would like an articulation of the plan's previous experience and current investment in effectively partnering with traditional and safety net healthcare providers. They're also seeking in C, previous experience and current investment in the areas of population health management as outlined in CalAIM. You know, CalAIM is now requiring the plans to have a population health management plan and to submit that as, you know, part of their requirements. And so some of these things are new. Under 3D, plans are asked to provide previous experience and current investment in providing in lieu of services like services outlined in DHCS. So we know that some of our plans are articulated in Health Homes program or have other internal programs where they are providing services similar to the state's menu of in lieu of services. And so the state would like the plans to articulate clearly what is that experience and how has that looked? What is the outcomes in the level of investment in those services? All right.
Can I go back just one slide? Because I think there's a sentence in here that is really interesting, and it may limit the pool of bidders because in order to meet A through D, you have to meet it as the prime. So you can't bring in someone else to give you qualifications for A through D. And so I think that means it probably, it's broadly interpretable. So you can have population health management experience similar to CalAIM and not have participated in CalAIM. I mean, not participated in whole person care or invested in anything California related. A firm from, you know, Arizona or Florida could say they have those qualifications because it's really about the population health management or the services that are described in CalAIM, but not particular to California Medicaid program. So I think that's something worthy to note. And the prime could be a new joint entity. So just be mindful of those things.
Excellent point. And, you know, the experience of the prime contractor also extends to the next two slides because question 3 has a lot of components. It actually goes from A through L. And so the prime contractor has to meet all of these requirements. So as we continue, question 3 also asks under 3E, what is the plan's previous experience and current investment in providing enhanced care management like services? You know, the plans currently have complex case management programs. They also do basic case management, but some may do more, some may do less. And so this is the section for them to articulate what has their past experience been and what current investments have they made. Under 3F, the state is looking for plans to articulate their previous experience and current investment in working collaboratively with local stakeholders. And that includes consumers, providers, advocates, and county officials in plan oversight and in the delivery of care. And so they would like the plans in this section to also include any program modifications that they have made to meet local needs and any outcomes that have resulted from that collaboration with those stakeholders. So this question 3F is probably going to be very important for the commission and its local stakeholders, particularly since we'll want to know what is the plan's specific experience here locally. And under 3G, the state is looking for the prime proposer to identify their previous experience, current investment, and knowledge in one or more examples to identifying and addressing social determinants of health and reducing health disparities and promoting health equity. That is quite a mouthful, but the intent of 3G is to really get to the heart of what is the plan's experience and what are they investing in around addressing social determinants of health? How are they reducing health disparities, promoting health equity? That state is looking for the plans to provide at least several examples and to demonstrate that they have knowledge in this area.
I think this is a great opportunity, both in F and G, to get more specific and granular. You can ask for data related to their experience or outcomes related to their experience, instead of just getting text about the fact that they know about health disparities and health equity. So you can ask for something more granular. And even in F, you can ask for that the list of local stakeholders include community-based organizations that might be homeless housing providers, or so you can get specific with what you're looking for in some of those items. So just think about what's missing there and put that in as a comment for those sections.
And finally, related to question 3, this is the final list, the remaining list associated with this question. So 3H is asking for the plan's previous experience and current investment in increasing access to care and care coordination specific to behavioral health and complex conditions. They also want 1 or more examples on how the plan is approaching increasing access to care and care coordination for individuals with behavioral health needs. Similar to that, in 3I, the state is looking for the plan's experience and current investment in children's preventative services and access to care for children, also asking for examples. That's probably important, particularly since children have very unique and specific needs. Under 3J, state is seeking the plans to articulate what is their experience, the current investment, and to provide examples of how they're approaching quality outcomes and innovation. And so this area could be very broad. In California, addressing quality is becoming more and more important. We see that raised consistently by the governor and by DHCS. And so this is an area where, if the commission is seeking specific insights or would like to, highlight anything related to quality improvements, innovations, section 3J would be a really good section to do that. And then section 3K is asking the plans to articulate what their previous experience, current investments are, and how have they effectively and successfully had conducted oversight of their delegated entities. And so this is going back to that question of subcap to other plans and other healthcare provider groups. The state wants to know if you've done and had delegated responsibilities to other entities, what's your experience in that? Give us a few examples on how you've conducted effective and successful oversight of your delegated entities, and how do you ensure that those delegated entities are providing access to care and delivering services as the state expects. And finally, in 3L, the state is looking for the plans to articulate their experience with diverse beneficiary populations and their challenges to ensure network adequacy in different counties. So again, they're looking for previous experience, any current investment, and a few examples of the plans to demonstrate success in providing services to a wide array and diverse beneficiary populations. So this is where we have vulnerable populations, the homeless population, the reentry population, just to name a few. This is an area where you can dig deeper and ask some additional questions. So that concludes question 3 under the proposing firm's capability section. There are 2 other questions. Question 4 is asking the plans to identify whether the proposer has had or been noticed of a contract termination for failure to perform. So have they ever had a situation in the past where they had a contract revoked or terminated because they were not able to meet all the terms of that contract? The state wants to know that. The state also wants to know whether the proposer has been removed from a government bidders list because of that failure to perform or to comply with financial requirements. So you can see how that's a very important question. And then question 5 is asking for 3 client references from the proposing firm. And the state has also said that the additional requirements are currently under development for this section and may be added to the proposing firm's capability section in the final RFP release. Okay. So that concludes the major sections that are available for review that have content developed. In those previous slides, we actually pulled the actual language from DHCS. And so when you go back and look in the RFP main, you'll see that they align pretty tightly. Our goal was to give you the actual language where there was language developed. But in these next 2 slides, we wanted to identify the attachments that are available for review and what they are. And so you'll see on this slide, we can review and comment on the proposal's cover page. There's a narrative proposal attachment checklist. What that is it's literally a checklist of all the attachments and certifications that must be included. And so, they're asking the plans to indicate what they're including in the proposal: client reference, payee data records, and record supplements. And then 5, 6, 7 are requirements in state law or federal law. So, the Iran Contracting Act is a federal requirement, the California Civil Rights laws. There's an attachment related to that that's fairly standard in state contracts, or conflict of interest compliance certification. So those are common elements that we see in many state RFPs with a lot of state contracts. 2 things, there is a attachment for request for inclusion on distribution lists. So the state will have a separate distribution list. If they make edits to the RFP along the way, you can ask to be included in that separate distribution list, both plans and interested stakeholders. And so that is for whenever there are changes to the RFP or to the contract, to the scope of work, that separate distribution list will probably be more nimble and be a little bit more real time in terms of what it disseminates. So I'm flagging that for the commission in case that's something the commission would like to have and be part of that distribution list. And then the letter of intent. What is not available and currently under development is on the right. So the plan model county proposer selection form, that's what counties are you going to apply for in this RFP. The attachment on evaluation questions and the proposer response guide is also under development. So those are not available for us to weigh in on or to review language, but those, the commission, it's certainly within the stakeholders, and the commission can certainly weigh in on what they would like to see in those attachments. in addition to attachments, there's an appendix section. And so the state is asking each plan to append additional information. There are 9 appendices. So they would like to see the actual Knox-Keene license. They want to see the actual NCQA accreditation certification. They're asking the plans to submit data around the annual quality performance measures. There are requirements around financial stability. There's minimum financial criteria that has to be met. And so in this section, they're asking for a lot of fiscal information for the plans to provide. They also want to see proof of eligibility to do business in California. So the licensing and certification with the Secretary of State, the proof of nonprofit status, if it's applicable. These are the types of things that the state would like the plans to include as part of their appendices. And as you can see there's attestations. There's a whole laundry list of attestations that the plans will have to provide, as lobbying restrictions and disclosures. And this is where, if they were to receive a county letter of support, they would attach that to their proposal. I'm going to pause there in case there's any questions about that. What plans are required to append?
I don't think there's questions there, Lisa. There's been a wonderful conversation going on in the chat that you probably haven't been able to see. So maybe, if there are any other questions that folks want to ask at this point, we can, do so now. If you want to continue to use the chat, feel free to do so. But we'll pause for a moment to just allow for a little discussion and see if Janine has any points that she wanted to make at this point.
This is Marvin Cameras, and I was just going to mention, as I did in the chat, that really nothing is changing here. I mean, we're adding Cal AIM and ILOS, which is important, but from a provider standpoint, working within several provider networks, several IPAs on the ground, the access to care, the barriers to care are not going to change whether we have. It's the same model. It's a GMC model. So either we have 2 plans that were financially working with the IPAs, or 5 plans working with the IPAs. But unless there's more access and more inclusion of systems that have historically walked away from Medicaid, some foundation model physician groups and some of the health systems, then the patients aren't going to have any difference in care. As a matter of fact, it may be even more difficult with 2 plans versus 5 plans. I'm most concerned about the games that get played between the 2 major health plans and the hospital systems, and between the Sutter system and the Dignity system. The 2 major plans, have alternating contracts, so that one expires and half the population is left without the ability to go to that health system, and there's realignment of the plan that the patient has through a particular IPA. For those of us who work in one healthcare system, like the Dignity system, if there's a contract that's going to terminate, and the majority of our patients are Medicaid through an IPA of that health plan, then we have no place. Those patients can't get care, and they can't get into other providers because the number of providers on the ground can't absorb the additional workload. So nothing is really changing here. That's my major concern. John, maybe you want to weigh in here.
I think you're talking about me, Marvin.
Yeah.
Yeah, and I think we I think we retain the complexity, that's for sure. And I think Dawn kind of alluded to that when she started talking about delegation and subdelegation. And I'm really excited that we have a commission and that we have an opportunity to encourage quality, you know, and just have a voice. And I'm hoping that that we can use that time on the 29th to do that.
Yep. Well, oh, go ahead, Janine.
Yeah, I was going to make a process note. Thank you, Dr. Kamras and Jonathan, for those comments. I am tracking them in the template that the committees and commission will review. So just want everyone to be aware, if you have questions, comment, or issues, to begin to add that to the template. I'm doing so as we go. And also, if you wanted to specify, Dr. Kamras, I don't know if you had a specific remedy that you are seeking to that comment, but I can note that as well.
The remedy is more difficult than the question, but let me think about that.
Sounds good.
Thanks all. Does anyone else have any comments right now, or do we want to let Lisa and Don continue?
Great. I think one of the remedy, I mean, I think what you also can be mindful of is in the comments, you don't necessarily have to have the solution. You can pose a question. How will DHCS, you know, mitigate what's currently, and Marvin, you can articulate like what's currently happening, like the dropping of, or the end of contracts and the lack of availability of providers, or the contracting between hospitals and health plans that leave certain populations without a provider group. So articulate the problem and then ask them how they will remedy it. And I think, you know, that's one way to at least identify the issue without, you know, thinking it through and giving them the answer.
Excellent points, Dawn. And so in this next section, we're going to be, and there's no other comments or questions discussion, we're going to review the proposed contract changes and tie it back to the DHCS identified goals. I am going to turn it over to Dawn to walk us through.
Great, thank you, Lisa. So what I want to do pretty quickly is just go through some of these contract updates. A lot of them are still in motion because many things are in draft. And so they may look different by the time the final RFP comes out, but it's good to know what's currently being updated. And so the goals will be added and expanded, and I think we've kind of walked through that. We've talked a little bit about population health management and the policy that is currently, those policies are currently in draft, and then you'll see them in the final, but you can always go back and look at what's happening with CalAIM and all of the ECM and ILOS. So that's number 2 and number 3. There are a number of carve-ins and carve-outs. So the transplants are being carved in, long-term care is being carved in. And so there is language that is in draft. If you have certain concerns about what is being carved in, meaning going into the bucket of management by the plan, or being pulled out, carved out, meaning it's no longer going to be the plan's responsibility to manage, those are things that you can comment on as well. I think when it comes to health disparities and health equity, those comments and requirements are in draft. So it's a great opportunity to identify what you're looking for with regard to health disparities, either by experience, performance, past performance, or metrics, and health equity. So what remarkable change has this health plan made with regard to health disparities, and can you show the outcomes or allude to those changes? Next slide, Lisa. Behavioral health and the no wrongdoer. I think, if there are certain aspects of behavioral health reform that you'd like to see, please comment on that, because those are things that are going to be updated and they're all in draft. I think for school-based services and early intervention services and behavioral health for school-based services and those affiliated providers, so that's a big bucket right there. There are policies that are still being developed, and if that is your area of specialty or you're worried about those populations, then please take a look at that, because that is currently in draft and is still being developed. The prescription drug policy is also in draft, but it's being updated. The budget's being updated. And so I think what you'll see is that there are a lot of changes that go back and map to some of the goals. There are a lot of changes that go back and map to all of the sections that are still in draft. And that means all of those things are open for comment. Next slide.
So before we go into the next slide, I just wanted to flag, a lot of these changes are really tied to broad policy changes happening within the Medi-Cal program. And so a lot of it's tied to CalAIM, but, as I mentioned before, the Medi-Cal prescription drug policy that, the governor has proposed a carve out of that. So that was not unexpected. And then I just wanted to mention for the school-based services, this ties into, even under ECM and iOS, under CalAIM, there's complexity around providing enhanced services to children, particularly for children with complex needs. And the intersection between health and education, that's still being worked on. So the complexity with the school-based services are probably fairly critical, especially when we think about, the overlay between schools, county, and the plans in terms of who has jurisdiction of what type of services. And in Sacramento County, this is where the local LEA that is supporting the local education area groups, those are going to be critical to working with the plans and the county on school-based services and support. Go ahead, Dawn, passing it back to you.
Thank you. So the next couple of slides really map the goals that were discussed earlier with the contract updates. So for accountability, data collection, and coordination collaboration with community service providers, for health disparities, so for the aspect of the goal that was health disparities in the category of accountability, what the contract will reflect is a requirement to have the plans have a health equity officer and a quality improvement equity committee. So that speaks to an officer and a committee. If there's other aspects of governance that you'd like to see, then you can talk about that there. They also identify the cadence with which the plan has to conduct a population health quality review of their program. So it's going to be a new program, and they have to then conduct an annual review. If there's something particular you'd like to see in that review, that's where you would make a comment there. They're broadening their responsibility to have cultural competency training to address the health equity concepts. And they're renaming that cultural competency training to diversity, equity, and inclusion training. And then they're updating the frequency of the reporting. For data collection, they're requiring expansion of their MIS capabilities so that they get the data from their population health management, which is going to be newly created, integrated in accordance with national NCQA standards, population health management standards. I'm sorry, I wanted to make sure I wasn't speaking over someone. And then they're also going to require that the plans have policies and procedures for sharing that information with third parties and county programs. And so this might be where you talk about the frequency with which you want that data shared, how you want those files, what data you want shared. That would be where you might want to comment in that section related to health disparities. And then the last section for health disparities under coordination and collaboration with community service providers is in that they're requiring that the plans ensure that provider participation in their QIS and population needs assessment. So how they do that is not articulated here, but they're requiring that the plans ensure provider participation. So if you have comments about how you'd like to see that happen with regard to health disparities and QIS, that's where you would put that comment. And then the requirements for third-party review and the county's program for care coordination and collaboration. If there are other aspects besides behavioral health, public health, and social services, and if you don't agree with it just being every 3 years, then that's where you would reflect an alternative. And then the infrastructure, if you want to articulate what type of infrastructure you're looking for as they coordinate with health and social services at the community and county level, then that's where you would make those suggestions. But those are the parts of the MCP contract that are getting updated. So it's a wonderful time to add comments for health disparities, for health disparity work. Lisa, any comments there?
Yeah, I was just going to add that, you know, this is really the state's way of working with the plans to address health disparities. These are the contractual levers. But, you know, this is really the first set. You know, the state really, you know, they're expanding its efforts on reducing health disparities. And so this could be an opportunity to weigh in on who may need to be included, who may need to be at the table. For example, to Dawn's point about coordination and collaboration with community service providers, and item 2, updating the requirements for review of third-party entities. You know, there was a discussion amongst the commission in the last meeting around homelessness and the need to better articulate that piece. So, you know, there's also an opportunity to highlight particularly vulnerable populations and to call that out as part of the contracting as well.
Great. So then the next slide is the categories are oversight and regulation and accountability, but this is contract updates related to oversight of delegated entities. So the prime contractor, the health plan, has to oversee what aspects of their contract they're giving away. So this is how they manage those partners or those subcontractors. And so what they're asking for, they're clarifying and strengthening some of those provisions. And there's a distinction between network provider and subcontractor agreements. There are going to be new requirements for each type of agreements. The contractor is responsible for all duties and obligations, even when delegated. So as a former federal staffer, when I wanted to call a contract in and the contractor said, well, I subbed this out to Lisa, you know, my response was, you're ultimately responsible for the work. So that's what C is basically saying. The plan is ultimately responsible regardless of who they subcontract to. So then the next one is really making sure that DHCS has the ability to enforce any subcontractor agreements directly to the subcontractor as well. So not only are they going to hold the prime responsible, but they also are going to be able to enforce at the subcontractor level. And then any actuarial judgment or federal approval is also strengthened. So oversight and regulation looks like they're taking a more interested view, and they're going to be heavily involved with what the prime and the subs do. And I think what's going to be important is, as you think about those community organizations and those community partners, what does this mean for them? So I think it's a positive, and then you also have to figure out what does that mean when the contractor might be someone that isn't as sophisticated as the classic MCP subcontractor. So accountability is, requiring NCQA accreditation for the prime and any subcontracted health plan. So where you get a newly formed entity that might consist of, 2 of your plans, and then the other 3 are subs. That's where that comes in. Everyone, regardless of their position in the contract, will need to be NCQA accredited. That any network provider enroll as a Medi-Cal provider, making sure that data on the network and encountered is reported, and then some certification of delegated entities for just network compliance is also added.
So here, particularly in terms of requiring all health plan network providers to enroll as a Medi-Cal providers, we know that there is a potential challenge for CBOs who are non-clinical in nature. And so this is where they're under CalAIM in the new ECM ILOS program. Those providers will not be required to enroll as a Medi-Cal provider because the plans, because they wouldn't pass that provider credentialing process. So in those cases, the state's going to allow the plans to develop their own process for credentialing, say, for example, a legal aid provider, or a Meals on Wheels, or a homeless services provider. And so that may or may not be an area where the commission would like to weigh in on. So I'm just flagging some of that as a potential nuance with what's happening in CalAIM.
Great. So the next, and I think there are maybe, I'm going to go a little bit quicker just to be mindful of time, and do a little bit of high level for some of these goals and categories, because these slides will be available to you as reference slides, and you can read them in much more detail than I'm going over right now. So the category is expanded provision of community advisory committee. So there are some changes to membership, and I think, if you look at those, it's composing the governing board of representatives from each county, and then also including diverse and hard to reach populations in that membership, making sure that meetings are open to the public, accessible, and equipped with tools and materials. So, given the impact of COVID, open to the public might mean, specifying that there are Zoom addresses and things that are available to make sure that that is public, not just posted publicly. And then the duties as well. And I think there are some cultural and linguistic policy changes and communication to make sure that it's culturally appropriate as well. And then under assessment of needs, making sure that they develop and engage different departments to have a holistic public health, population health management program, and look at the population risk stratification and member risk assessments that account for some of their social determinants of health. So really making sure that they understand the communities that they exist in and that will provide care in, and that the community is fully engaged in their work and in their governance, and that they assess the needs of the community.
In some of the commission members or your stakeholders may already be participating in these community advisory committees. And so this is an opportunity to weigh in on how well that's working, if you know, there are certain recommendations, suggestions, or certain things that the commission would like to see. This would be a good area to weigh in on.
So for access to care, there are some data updates regarding HCPCS codes and what results from the finalization of ECM and ILOS services in order to monitor performance, and then expanding the interoperability of their MIS system to make sure that there's ability to exchange data with other HIT and HIE networks in the area. For service delivery and outreach, it's really making sure that there are MOUs, memorandum of understanding, across the delivery systems and agencies so that there isn't redundancy in either what's being delivered or how it's being delivered, and that there's an enhancement of case management. There's telehealth. I won't go through the list, but I think there's a lot of contract updates relative to delivery and outreach of service. And then there's the clarification of some of the coordination requirements. And a lot of this has to do with the requirement around population health management and how things are going to be articulated in these new programs that they're setting up, and these policies and procedures that will be required of the plans. Next slide. For children's services, the two categories are access and accountability. And so there's some clarifications around EPSDT benefit, MOUs again, the contracts. And so if there is a lack of access, I think it was alluded to earlier, if there are concerns around access, take a look at some of these contract updates. And if you see that something is missing, or if you want additional detail, please make comments on some of these areas so that the children and children's services and behavioral health services for children are paid attention to based on what the need is in the county. Next slide, Lisa. Goals for quality and contract updates for quality under metrics and reporting. So I think, you know, some of these are existing, and so there are new improvements for PIPs and EQR standards, and there's going to be a new DHCS Chief Quality Officer who's also going to be revamping the quality and equity strategy for the state. There's going to be some alignment with data monitoring and understanding grievances, appeals. And then they're going to require that MCPs meet quality care benchmarks. And so I think, you know, maybe there's some information we want to see about the benchmarks. And if there is additional detail there, that might be a good place to comment. Accountability requiring NCQA for the contractor and the health plan subcontractors, and then some expanded audit provisions. Under incentives and penalties, they're strengthening some of their authority in payments for quality and how risk and incentive agreements are delivered. So it looks like DHCS is really strengthening their oversight of what incentives and penalties look like in those agreements. So I think if, you know, if the providers are concerned about how incentives and penalties right now look under their contracts, then this might be a great place to also comment.
So
Okay.
that concludes the contracting section. You know, it's important to recognize that we did not do a full review of the entire contract because there's a lot of standard terms that are already in it. It's like a 300-page contract, and that is the standard contract available. And then there will be 2 other contracts that the state will make available as part of the final RFP package, and that's not available for us to weigh in on. But the state provided this set of slides for stakeholders to understand the types of changes that are going into these contracts and or the types of changes that have already been made. And so we're providing them to the commission as a way of responding to those comments, to those changes in those contracts. And of course, the commission is also, it's the commission's prerogative to weigh in on any aspect of those contracts as well, or that contracting process. But we thought that would be an easier way of digesting and understanding those contract changes rather than going through a 300-page and all the details, because that would provide a layer of confusion. But we wanted to talk a little bit about what the evaluation and scoring process looks like. So Dawn, take it away.
Sure. So once the RFP is in its full and final format, each of the plans will, write per section and respond per section based on those requirements. Once the procurement closes and all bids must be in, then not too long after that, there are a number of committees that are being set up now or will be set up to review and score these proposals. And so DHCS is taking a multiple stage evaluation process to score the proposals. It's very clear and standard that they, can reject any proposal that they find to be non-responsive, meaning is not meeting the requirements at any stage of the evaluation. So the first group is called a PRC, which is preliminary review. And their goal is really to just do a compliance review. So if I stack all the requirements from however many pages and however many sections and subsections, if I go through the form to see who has met all the requirements, then they are compliant with the requirements. It's not a review, it's a compliance check to make sure that they are compliant with the requirements and everything is in the proposal to be reviewed. So that's the first stage. The second is the evaluation scoring committee, and that exists of different staff at MCOD and staff from other parts of the Medi-Cal program, and they do the actual review of proposals. And then the last group is the Rating Review Committee, or they'll be known now as the RRC, and they interact throughout the evaluation process. So they can consult with anyone in DHCS, other state departments, or independent consultants that are tasked with supporting the evaluation and scoring of proposals. Next slide. So as you go through the compliance review, a lot of the work that the PRC does, and because it's a compliance review, you either meet it or you don't meet it. You pass it or you fail it. And so packaging and label, all the required information, they have their discretion to ask for missing forms, going back to ask for attachments or signatures. Some of those things classically get overlooked. I don't know that this is a big section that you want to comment on, but you may have some comments about the process. But this is where all those things happen in stage one. You either go to the next stage or you become non-compliant, and you can be removed from further scoring in stage one. I'll pause to see if there are any questions.
10 minutes.
Okay. Stage two is still under development, as are many things right now. And Stage 2 is really to make sure that formatting and qualification requirements are there, and there will be a review and evaluation of and scoring of the sections in each narrative section. So this is, an exhaustive process where you have to read through all the proposals to make sure that the question asked is thoroughly responded to, and to what degree has it met the requirements of the RFP. So this is where points are assigned, and there's a 1 through 4 point system. I'm sorry, a 0 through 4 point system, where if your score for a section is 0, means that it's inadequate and you either have not fully met the requirements, expectations, you've forgotten something, there are significant flaws, or it's just plain unacceptable, and that's the discretion of the scorer. And so you can get a 0 on a section. 1 is barely adequate. So you really don't meet the requirements. You may have some content there that makes it not inadequate, but it's barely adequate. And then 2 is adequate. So 2 is, there's a basic expectation that you've met, but it's average for quality and isn't exhaustive and fully developed from the evaluator's perspective. More than adequate and outstanding are 3 and 4. So you have, usually there are data points in an excellent or outstanding response. You're able to really understand their methodology, their approach. They've met the requirements and have provided, very concise and clear examples of how they meet it. So the review can go from 0 to 4, and those points are assigned per section by the review committee. Next slide, please. So what's also under development is how things will be weighed. So is the rating for section 1 going to weigh more than section 2 versus section 3? And usually there is some heavy weighting on scope of services, past performance. There are sections, so if you go back to the very beginning of the RFP, where they lay out the different sections of the proposal, the sections that go under, so organization and administration of the plan may not be worth as much as network agreements or provider relations. Section S usually has different weightings than section O, qualification requirements. So that's how the weighting will work. And then the weight versus the score will give you the maximum points, and then they will total those scores up. Again, if you have any comments about how you want things weighted, so if you look at the list of sections and you want to make sure that a section is heavily weighted, then that's where you would put those comments as well. So there's the opportunity to weigh in about the scoring. Okay.
Great. Thank you, Dawn. Let's talk a bit about the RFP timeline and submitting comments.
So we wanted to give you a visual of the procurement timeline. Some of these events have passed. You will note that the draft was released June 1st. There was a webinar on the 10th. The questions and the comments are due back to DHCS by July 1st. I believe there is a commission-specific timeline date in there as well. The letters of intent are due July 1st as well. And it's interesting to note that they are voluntary and non-binding. So a plan can say, yes, I am going to bid, and then turn around and not bid, and they're not bound to bid. I'm not sure if they can bid if they don't submit a letter, but I'm assuming that if they're non-binding, then you don't have to submit a letter and you can still bid.
That's correct. That's correct, Dawn.
Great.
They would still be able to bid. Mhm.
Great. And then there are some dates relative to model changes and amended bills. And Lisa, do you want to kind of go into that and just talk a little bit?
Yeah, I can do that. So this has to do with, so the state made it open to all counties in case they wanted to change their county Medicaid managed care model. Certainly that was a discussion here in Sacramento County, but a number of counties have expressed interest. There's about 17 counties that are in the midst of this process. And so in California, this is a multi-stage process where a bill has to be passed by the legislature. And so there's timelines related to passage of legislation. The last date, just to flag upcoming deadlines, the last day to amend any bills moving and making a change to the county model is September 3rd. And the last day to pass a bill out of the legislature is September 10th. Between that and the day when the deadline for the governor to sign and veto bills, the DHCS would like all approved county ordinances filed with them by October 1st. And the governor has until October 10th to sign any of the bills related to county model change. Certainly, there is a bill, I believe it's SB 266, a PAN bill that is addressing this specifically for Sacramento County. And so those are some key dates for the passage of that bill.
Thanks, Lisa. And then the RFP timeline, we won't go into too much detail. You could see that they're targeting the final for late November or early December. So a great holiday present for the plans to get started working on. And then there will be, of course, a proposal conference to just go over the RFP. They allow the plans and anyone else that has questions about the RFP to post questions. And that's usually 7 days after the RFP is released that is done. There'll be another request for letter of intents. The proposal due date is usually 2 months after the RFP is released. And then there'll be a notice of intent to award. These proposals, this RFP can be appealed, and in counties where you will see a reduction in the number of plans, there may be appeals depending on how the plans work together to propose to cover the counties that are looking to decrease the number of plans in an area. So just know that there is an opportunity to appeal. There's a contract award date, which is after the appeal. And if there are no appeals, then it moves much quicker. And then the operational readiness is targeted for late 2022 or 2023. But full go live is anticipated in January of 24. So it seems far off, but it actually is not once you get into the moving through this process.
And yeah, the MCP operational readiness is a critical component because during that year, that's when before plans can go live in a new county, there's a number of tests and milestones that they have to meet to demonstrate that they are ready to go live. And the goal would be to have the new plans and these new contracts implemented January 2024. But we wanted to flag the appeal deadline because depending on what, if any plans were to appeal that may add some additional time, and that, you know, the commission may want to know about which plans are appealing as part of that process.
And then I think this is our last slide before we get to resources that are available for you after this call, is that we are looking to, and Janine, please chime in if you want to walk through this slide, feel free to do so.
Sure, thanks, Dawn. So as I mentioned earlier, during our call, I was taking notes about any comments in a template, which I will send out to the commission by Monday. And that is a format that adheres to DHCS's submission format here. So provides all that detail in a clean and organized way for individual commissioners to add any questions or comments to that document. And the committees will also be using that document for their comments and questions. And that will be due to me by next Friday, no later than 1 p.m. And I'll compile everything in time for the commission meeting on Tuesday, the 29th. Any questions about that process? Okay.
Great, thank you. So to wrap up, Dawn, would you like to walk through the resources that are available to the commission? You're on mute, Dawn.
Sorry about that. What we've done is provided a number of links that will take you directly to the content that you need to review in order to place some comments. So the procurement, the timeline, the current models that are in each of the counties. So there's a map and there's a fact sheet there. There's some documents on the model plan transition, the letter of support, and then the current contract. Those are some of the resources. So it's a download. It's a lot of information. We've given you a high-level overview in this deck, but you'll definitely need to go back to the procurement link to help you formulate your comments. Next slide.
Yeah.
Oh, go ahead, Lisa.
Oh, I was just going to mention this procurement link and the MCP contract link is probably the two most, the two links that you'll want to pull down first, given that the procurement link will have the RFP main and all the sections of the RFP, and this current MCP contract, this is the current contract that's in place. And so if you wanted to read through and know what the current requirements are, that would be your reference material. But the slides we provided today around the new and upcoming changes will not be captured in the current MCP contract. So you'll want to reference the slides for those changes.
And then this slide just gives you a sense of what's currently in the contract and then what's going to be restructured. So where things are moving to. And so when you read that current contract, you can look at Exhibit A on the left-hand side, and then these things will be shifted over to different attachments. So you'll be able to see that systems and processes will be in attachment 3. Anything related to providers are in attachment 3. Members in attachment 3. So instead of being separate attachments, they're grouping operations, operational readiness, and definitions into different attachments. So that's the shift to probably help with oversight and contract compliance, I'm assuming is why they're making the restructuring shift.
Thank you, Dawn and Lisa. So actually we have a kind of a time certain, we're a few minutes off of it to call for public comment. Is this, I don't know how, are
We are at the end.
okay, so I apologize if we can do, let's take public comment and then we'll ask if there's any, we can also ask if any members have comments depending on how the public comments go first and kind of close out with you. Really appreciate it though, both of you. Is there any public anybody in the meeting now that would like to make a public comment based to the commission? Anyone that wants to make public comment? Okay, I'm not seeing it. You can raise your hand or come off mute if you want to make public comment. Okay, not seeing anybody wanting to make public comments, so I think we're comfortable to close that out unless someone pops up. So Lisa, Dawn, sorry to interrupt. I think technically I was supposed to do that 5 minutes ago. So, but really appreciate everything you brought to us. Do any members, since we're technically, I want to be cognizant of folks' time, but do any members have comments that you want to make now? I know we were kind of asking questions as we went along the way, or if any members have any questions for Lisa or Dawn about anything they presented on, now would be the opportunity to say that. Otherwise, next steps we're both subcommittees are meeting next week, and so we'll be getting into this as well, and diving in with our committees. Those are also public meetings, so feel free to check out the commission's website to get information about that, each of those, and then we will finally circle back to kind of bring all those comments together at our June 29th meeting. And as a commission decide on which items we're going to adopt to provide comment to Department of Healthcare Services on the draft RFP. Lisa, Dawn, Janine, you have anything you want to add?
No,
right.
we'll make the deck available to everybody after this call. I know Janine's planning on sending it out with the templates. And if there are any questions, don't be shy, please reach out.
Thanks, Lisa. Really appreciate it. Thank you so much, Dawn. Really appreciate both of you giving us that great overview. And Janine will be sending out the materials. And so I think, is there any other comments, or is there a motion to adjourn by the commission?
I move to adjourn. This is Deborah.
Thank you, Deborah. Is there a second?
I second, Michelle Monroe.
Thanks, Michelle. All right, well then we're adjourned. Thank you all.
Thanks everyone.